Hello, good afternoon, everyone. We will start in a couple of minutes. Okay? You can hear me, right? You can hear me clearly?
Yes.
Thank you. I just want one person to start camera, only one person, just to make sure that I am not talking in the vacuum or blank space. Only one person, any volunteer. Okay, good. Thank you so much. I appreciate that. Thank you, Jonah. Thank you, Jasmine. Thank you, Amir, Mrs. Abram. Thank you, everybody. Thank you, Michael. Thank you, Jipro. Everybody, thank you so much. All right, so I guess we can start. Let's get started. All right, it's 3:31. So let's wait maybe for one more minute and then we will start. If anybody else is going to join, I don't want them to miss our discussion. So thank you for joining with us today. I really appreciate it. I know you are very tired. You have a very busy schedule, DO and MS both, and I appreciate that for coming and joining on this Zoom session. It is being recorded, so those who are not going to come, they can still view the recording on discussion later on. I'll post this recording hopefully by tonight on Canvas, so they will still view the recording later on. But coming to the session, I think it's more fruitful, more important because it will make this class session more interactive. You can participate, you can answer the questions, you can ask questions, and that way I can help you guys accordingly. So being in the session is better than not to be in session, but I understand students are very tired, very busy, so that's why I changed it to the Zoom just to help you guys out, so you guys can little bit relax, rest up, sit, and then listen to me. And if you have any questions, I'm more than happy to answer it. And you know, we will basically do the same thing what we have done yesterday. I will pose the questions. I'll start the poll. You will try to answer the question, and then we will go from there. We will discuss why XYZ is the right answer, and why rest of the distractors are not the right answer. Okay, so we'll go step by step. This is how we did today and yesterday in the class. Okay, this is how we've been doing since beginning, because obviously I want to know why behind each and every answer. You know, it's a mechanism based discipline. It's a technical discipline. There is always a why behind each and every answer, so we have to explain the underlying hardcore principles of physiology, and come up with your own explanation to answer the questions why it is the right answer. Okay, if you come up with your educated guess, that's a good thing. If you come down or arrive to the right answer, that is good. But definitely I want to know why you picked up the right answer. You have to explain, or we can discuss it, as we did to yesterday. We'll discuss the concepts and find out why that A or B is the right answer in that question. Okay, all right, so let's get started. We have 65 students, which is enough. 64 if I exclude myself. So I'm also a student. I'm also a student, by the way. All right. So we discussed about this sodium and potassium balance yesterday on the Zoom, and we talk about all this concept yesterday. We discussed this slide. We discussed this slide yesterday. We discussed about all of these different segments of nephron, and we talk about each and every epithelial cells of each segment of nephron, and how they communicate individually and how they communicate with each other in order to sustain fluid and electrolyte balance within normal physiological range in a normal healthy person otherwise. So we discussed all of this yesterday. Remember, this both are primary active transport mechanism because they have their own ATP. As you can see here, there is no ATP here. There is no ATP here. They are all secondary active transport. These two transporters, which are located on the luminal membrane or apical membrane of alpha intercalated cell of late distal tubule and collecting duct, they both are primary active transporters because they use their own ATP. And this can ring the bell that you just learned in GI physiology about hydrogen potassium exchange or pump or proton pump. So it's the same pump you will find out here that you also learned, which are also located in the luminal membrane of gastric parietal cell, which is involved in the gastric acid secretion or gastric acid regulation, and that is targeted to inhibit or to modulate the activity of that pump by a drug called proton pump inhibitor. Okay, we talk about that in GI, so you know that. And this is the principal cells. They don't have any primary or secondary active transport mechanism on the luminal membrane. They have mainly the sodium and potassium channel, which are located in the luminal membrane. It's called epithelial sodium channel and epithelial potassium channel, which are located on the luminal membrane of principal cells of late distal tubule and collecting duct. And all these channels, which are they are under operated under the direction of the aldosterone. It's a fine tuning segment for sodium and potassium regulation mediated by aldosterone. Aldosterone will basically express, recruit, populate, and activate sodium channel and potassium channel in the luminal membrane of principal cells. And aldosterone at the same time will activate and increase the activity or population of the sodium potassium ATPase pump on the basolateral membrane of principal cells of late distal tubule and collecting duct. Okay. So we'll talk about that more. We discussed all of this yesterday. We discussed this question yesterday. So you guys, okay, let's get to this question. I'll start the poll and then you can try to answer the best you can and we will discuss. We'll go from there. Okay. All right. I'll launch the poll. Try to answer it and we'll discuss later on why one of them is right answer. Rest of the distractors are not the right answers. Give you
Dr.
5 more
Shah,
seconds. Yes.
Dr. Shah, should we know normal ranges for some of these ions that we're talking about for the exam?
Yeah, I will try. I will try to give the normal range in the question stem. But yes, you have to know that. You have to know
Okay.
normal range for sodium, potassium because you learned it. You obviously knew it because you learned it in foundation block, right, Jasmine?
Yeah.
Yeah, you have to know the normal value for sodium, potassium, chloride, calcium, magnesium, everything. All right, I'm gonna end the poll. And Jasmine, actually, it's a very good question. When you practice questions, which in the Q bank that I posted, and other questions that you practice from our clicker or supplemental or exam review or TA, once you practice more and more questions, you will automatically remember the value. Okay, you don't have to really force yourself or to memorize the number, right? It just comes automatically. All right, I will end the poll. It comes with the practice, right? So,
Yeah, thanks.
yeah, sure. Yeah. All right. Good job. Looks like good response rate. All right, so who can explain that why C, beta 2 agonist, is the right answer? What's going on here? Why you want to use beta 2 stimulant or beta 2 agonist in this patient? Yes, Mrs. Abraham.
So the way I approached it was I went with the beta 2 because beta 2 receptors are in like the lungs. So we want to dilate her airways he or she so they can breathe better.
Very
That's
good.
how I
So
went.
good. So that definitely will help to some degree in this patient because beta 2 is a bronchodilator. It will relax the smooth muscles of the bronchial tree. And we use the drug albuterol or rescue inhaler or many drugs which are designed and available in the market. They are beta 2 agonists and is widely used in practice to treat bronchial asthma, right? It has a more instant or immediate effect because as soon as the patient takes it through the inhalational route, it will directly go to the lung. It's a targeted drug delivery, and that will dilate the bronchus or bronchial tree quickly and will give instant relief to the patient who have bronchospasm, and that will also help in the shortness of breath because when you relieve bronchospasm, it will help in the shortness of breath because patient can easily breathe now because it's a bronchodilator. Good, but what is the problem here? Why I'm asking this question? You are correct. It will help you. It will help the patient to some degree by bronchodilation. But what is the actual cause of muscle weakness and shortness of breath in this patient? And we did talk about that yesterday. Yes, Kirilos.
So the muscle weakness is due to a lack of potassium, which means that the action potential isn't going properly. So the beta 2 agonist is going to promote potassium movement into the cell and allow for action potential to occur.
I love it. Outstanding. Outstanding. So now let's go back to the problem. Good job. So obviously, he said, Kirola said correctly that beta 2 agonist will basically shift potassium from ECF to ICF, or it will increase the uptake of potassium from ECF to ICF and will correct hyperkalemia, right? That's what you said. Good. Okay, so good. That's good. But why there is a hyperkalemia? Why this will result in hyperkalemia in this patient? What's the cause of hyperkalemia that are there in this stem that can make you think that this person can result in these things can result in hyperkalemia in this patient, and you want to give beta 2 agonist to correct hyperkalemia. So what is the cause of hyperkalemia in this patient? We talked about that yesterday very in detail. Yes, Fatima. So it's good, as I told you yesterday, we can repeat this concept again and again. So it will, I keep reinforcing. It will stick to you eventually before you take the exam. Yes, sorry.
Is hyperkalemia caused by exercise?
Yes, very good. What is the mechanism? Why? Remember, as I told you, I want to know why behind every answer, behind any explanation. That is physiology. If I do not explain that, if we do not discuss it, it's not physiology. Okay, that's a cheating with you. I'm doing cheating and I'm cheating myself. So we have to make sure that we explain the concept or mechanism behind each and every answer explanation. So you are correct. Strenuous exercise or vigorous exercise can result in hyperkalemia. You are 100% correct. Why?
Is it because if you increase exercise causes potassium to shift out from the cell? So that's how it results in hyperkalemia.
I love it. Why? What's the mechanism? You are correct. Why?
Shift of potassium out of the cell.
Yeah, why it will result in out shift of potassium from ICF to ECF. You're right. Exercise will induce.
Pump will be activated.
Which one?
The sodium potassium ATP pump will be activated, so more potassium will shift out of the cell during exercise.
Okay, if sodium potassium ATPase pump is activated, what would happen? It will result in hypokalemia, right? Because it will shift potassium inside, not outside, right?
Yeah.
So that's not correct. What is the rationale for having hyperkalemia, which is induced by vigorous exercise in this patient? Come on, read the stem. Read the stem carefully. Yes.
Is it because of the production of lactic acid due to exercise, which leads to acidosis, which leads to balancing the pH, sequestering hydrogen ions into the cell, into ICF, and exchanging potassium out of the cell?
I love it. I love it. I will take that explanation as one of the major contributor of hyperkalemia, and I just discussed about that in the class. So thank you for picking this up so quickly, because we just talked about acid-base disorder in the class, and it looks like you got it. You guys got it. So good. You produce more acid in a vigorous exercise, and you have more acid, which will result in acidosis in the blood. And then you have more acid in the blood. H plus will go inside. But then why H plus will go inside? We talk about that, right? Why acidosis? H plus will go inside the cell.
Is it due to lactic acid because it binds to it and goes inside the cell?
No, I get that. It is lactic acidosis, right? We talk about it in the class too. So when there's somebody is doing a vigorous exercise, obviously they will result in anaerobic oxidation or respiration, and that will result in accumulation of lactic acid, and that's why there is acidosis. I agree with that, and I agree with what Diego said, that will result in hyperkalemia. But why H plus will go inside in the cell first place? Why you want to put H plus inside the cell? Why you want to get H plus inside the cell? Why don't you keep it outside?
Metabolic acidosis?
I'm sorry?
Metabolic acidosis?
Yeah, that is metabolic acidosis. My question is that why want to shift hydrogen or proton inside the cell? That's my question. I really want to post this recording, and everybody should listen to this recording now, because I'm going to break it down, all this concept, in a small pieces, and then you can thread it out to see the full picture. And why at first place H plus will enter inside the cell in acidosis. Yes. Oh, you are putting in the chat. To see the chat now. Yes, good job. Outstanding. So H plus will go inside. I just read the chat. H plus will go inside to get it buffered. There are buffers in the ICF. We talk about the protein and hemoglobin. So you want to get H plus buffered, and that's why H plus will go inside the cell. Good. Now H plus goes inside the cell. Why it will result in potassium shift outside? Why potassium will come out?
It's an exchanger.
Good. But why you want to shift potassium outside?
Obviously,
the logic is that there is a high potassium inside the cell, so potassium is more likely to shift it out very quickly and easily down its electrochemical gradient. But why potassium will exchange with hydrogen on this cell?
Because otherwise you don't keep your electric balance, your charge balance.
I love it. So as we discussed in acid base and yesterday, you want to make sure that you cannot violate electroneutrality of blood, right? Blood is electroneutral. There is equal number of cations and anions in the blood or any biological fluid. So when we add that together, all the charges are equal, plus and minuses, so they will become zero. And that's why blood is electroneutral. And that's why I explained that yesterday, that when you use the potentiometer to measure the electrical potential of blood, it is always 0 millivolt, because there is equal number of cations and anions. And that will make the blood electroneutral. So if you shift hydrogen inside the cell in case of acidosis, because then you lose 1 plus in the blood from ECF compartment. So you want to shift potassium from ICF to ECF to maintain the electroneutrality of blood. 1 plus goes in, 1 plus will come out to maintain the electroneutrality of blood. Good, which will result in hyperkalemia. Is everybody clear about that? This is the best explanation. Nobody should miss this. Everybody get it? Thumbs up or thumbs down? Good. So now that's to maintain electroneutrality. H plus goes in, potassium will come out, and that will result in hyperkalemia in vigorous exercise. What is the other cause of hyperkalemia because of vigorous exercise? What's the other rationale, other mechanism, or other basis of development of hyperkalemia in case of vigorous exercise? What's the other mechanism? Well, cell lysis is less likely to occur in a healthy person. It may occur, but not to an extent that can result in hyperkalemia. Cell lysis is more about if you use a drug, for example, anti-cancer drug, then yes, it can result in cell lysis by apoptosis or necrosis, because the drugs which are used to treat cancer or malignancy, that can destroy the cells and that can result in hyperkalemia. So that can happen if you use anti-cancer drug, or in case of rhabdomyolysis. It's another clinical condition where there is a muscle cell rupture that can release a large amount of potassium from ICF to ECF down its electrochemical gradient. That is true, but in this case, it's less about muscle lysis. What is the other cause of hyperkalemia? I will tell you guys. What happens is that when you exercise, you consume ATP. Remember, you will consume ATP, and there is a specialized channel which are located in the cell membrane of each cell is called ATP sensitive potassium channel. It's called ATP sensitive potassium channel. So when you exercise, you consume ATP, and that will deplete ATP. It will deplete ATP. ATP will be depleted because you are exercising and you are consuming ATP. When ATP is depleted, that will be sensed by this ATP sensitive potassium channel. Look at the name, ATP sensitive potassium channel. So it will sense the change of ATP. It's called ATP sensitive potassium channel. So when you deplete ATP during exercise, it will open up this ATP sensitive potassium channel, and that will release potassium from ICF to ECF in a large quantity down its electrochemical gradient. That will result in hyperkalemia. The most important contributor, the most important mechanism is this, and the second is acidosis. Okay, good job. Now look at the stem again. Read the first sentence. What is the problem in this patient? Why this patient is more vulnerable or more prone to have hyperkalemia compared to you and me? We can do severe exercise and we don't develop hyperkalemia that suddenly, but in this patient it is more likely to happen. Why this patient is more likely to have hyperkalemia compared to you and me if we exercise vigorously? Read the stem carefully. I discussed it thoroughly yesterday. What is in the stem? What is this patient is problem? What is this patient? What's the diagnosis of this patient? What's the problem in this patient?
Chronic renal failure.
Chronic renal failure. There you go. So when there is a chronic renal failure, you do not filter enough potassium. So that will result in hyperkalemia at first place. So CRF will make it more worse to the patients, those who are exercising vigorously. The patient is already having a CRF, so the patient is not able to filter potassium at first place. So that will result in hyperkalemia. Plus, in a CRF patient, if the patient will do vigorous exercise, they are more developing quick hyperkalemia more rapidly, more quickly, because of all the mechanisms that I just explained to you step by step. Excellent. And obviously, what you explained earlier about the action potential thing, which is correct, that result in because of hyperkalemia, there is a decreased drive of potassium leaving from ICF to ECF. There is decreased driving force because there is decreased electrochemical gradient, because there is a hyperkalemia, and that will actually depolarize the cell membrane partly, and that will inactivate the sodium channel. And when you inactivate sodium channel, no matter how strong you have an inward stimulus, strong stimulus, there is no inward sodium current, you cannot fire action potential. When you cannot fire action potential, it will result in decreased muscle contraction or muscle weakness. Good, perfect. What is the cause of shortness of breath in this patient? How hyperkalemia will result in shortness of breath? I just told you about that. It will result in muscle weakness, right? But what muscles are a prime concern here? They can result in muscle weakness. They can result in shortness of breath. Diaphragm, very good. Diaphragm and intercostal muscles are involved because they are skeletal muscles, and they have issues in developing action potential now. As I just explained the basis or rationale, that will result in shortness of breath because diaphragm is not contracted optimally. It's a weak contraction of diaphragm and intercostal muscles that will result in shortness of breath or difficulty of breathing. This is called complete explanation of this stem. We discuss everything here. Nothing is missed now. Good. Now, based on what we have found out so far, we are is confirmed or we are convinced that this patient is having a hyperkalemia for various reasons, and that's why we have to give beta 2 agonist to shift potassium from ECF to ICF, or to increase uptake of potassium from ECF to ICF to correct hyperkalemia. This is the complete explanation of the whole stem and answer. Okay. Now, one more thing to discuss before I get to next question, because you guys didn't tell me why beta 2 agonist will correct hyperkalemia. How? What is the mechanism? Yeah, well, you said that it will shift potassium from ECF to ICF. I agree. It will increase uptake of potassium from ECF to ICF. I agree on that. But what is the mechanism? What is the mechanism? What is the mechanism? Beta 2 will stimulate membrane bound sodium potassium ATPase pump, and that will increase the activity of this pump, which will increase the uptake of potassium from ECF to ICF. Everybody clear? Thumbs up. Yes or no? Good. Perfect. So that's complete explanation of the stem and answer. Why beta 2 agonist is the right answer. This is how I would like you guys to think. Generally, for any subject, especially physiology, but anything. This is how I would like you guys to think, to make sure everything is whatever is there, you understand the concept behind that or rationale behind that. Yes, Mrs. Abraham.
Do you mind doing, it could just be like one sentence, like a summary of this, just because there was a lot of answers.
Yeah, it is I know it's being recorded, and you can view that recording later on. No worries about it. That's why I'm recording it. That's why I changed it to the Zoom. That's another reason why I changed it to the Zoom. It's a lot to say in one sentence, because there is a chronic renal failure, and strenuous exercise together will result in hyperkalemia. For the basis I explained to you why there is a hyperkalemia. Hyperkalemia occurs because of CRF and vigorous exercise, and that will result in muscle weakness and shortness of breath. That's why the symptoms, you can see these kind of symptoms in the patients. And when there is a hyperkalemia, you have to give a drug that can shift potassium quickly from ECF to ICF, and the drug is beta 2 agonist that will stimulate sodium potassium ATPase pump, and that will correct hyperkalemia.
Thank you.
Okay, sure. All right, good. Why? What is E? Why E is not the right answer? And that will also explain what Fatima just said earlier. Why? What E will do?
Would E have the opposite effect of a beta 2 agonist, where since the beta 2 agonist stimulates the sodium potassium ATPase pumps to take up calcium,
Right.
E would stop them from taking up calcium, leaving it all in the blood and making it worse, right?
Right. It's not calcium, it's potassium.
Potassium, sorry. Yeah.
Good. Now, what is that drug that you learned in cardio and foundation block? Especially cardio, I talk it thoroughly about that drug, which is still used in practice to treat congestive heart failure, because it's a cardiotonic drug. It has a positive inotropic effect. It will increase the force of contraction. It is still used with caution in some patients, and that drug will inhibit the sodium potassium ATPase pump. What is that drug? That can inhibit this pump activity, and they can make this hyperkalemia worse. What is that drug? That's why it is contraindicated. That drug is contraindicated in this kind of patients. Or that drug, when you prescribe that drug, you have to be careful, cautious, and you have to watch. It's notorious, so you have to watch the side effect of that drug. What drug we discuss in cardio? That inhibits sodium potassium ATPase pump. That is used to treat heart failure. Come on.
The chat says digoxin.
Very good. Outstanding. So that's cardiac glycoside, right? Cardiac glycosides. Very good. Super. Outstanding. So we talk about that. Let's go to the next question. All right, I'll start the poll now. Yeah, I can simply tell you, yes, good, right answer, but that's not enough. we have to discuss thoroughly to come down to the right answer, why that's the right answer. We have to explain everything thoroughly. You have to know everything, really, because this is what is physio. This is actual medicine, foundation of medicine. And it will immensely help you to the first year DO students, not only for our exam, but also for the board exam. So thank you for coming, who came or who are there. I know there may be more than what I see because you may be in the group. I know that happened a few times in the past. So I know that, but it's very critical session, very important. And I'm going to talk about other things, sort of other concepts, which you have to know for second year and for the board exam and for our exam too on Wednesday. I'm happy that I changed it to Zoom because the students are tired and they can rest and relax and listen and participate. And at the same time, I can record it so it can be viewed later on as well. So I'll give you 5 more seconds. I mean, it's a big stem, so I just want to give you a little more time. I'll stop at 2 minutes, okay? It's a big stem question. Do you have enough time to read and interpret, understand the question? All right, I'm going to end the poll. Okay, good job. You guys are doing pretty good job. All right. So who can explain that to me? Why insulin?
It says the potassium is high, so that means there's hyperkalemia, and so we want to shift potassium from ECF to ICF, and
Yeah.
that's why the insulin is used here because that helps activate the sodium potassium at ATPase pump to bring
Yeah.
to bring potassium in.
Outstanding. This is called complete explanation of the right answer. Thank you so much. Very good job. So insulin will basically activate membrane-bound sodium potassium ATPase pump and will increase the uptake of potassium from ECF to ICF. This is how it will correct hyperkalemia because there is a clear indication in the stem that this patient is having a hyperkalemia because of the level of potassium is very high, 6.8. Is 3.5 to 5 is the normal range. So at 6.8, so it's definitely higher than normal. And that's why, and I put normal here too. The range is 3.5 to 5. So that's why the patient is having a hyperkalemia. We know that, and insulin will shift potassium quickly from ECF to ICF by activating sodium potassium ATPase pump. This is how insulin can correct hyperkalemia very quickly, efficiently, and can save the patient. Good. Why this patient develops hyperkalemia? One more time, and then we can go quickly to the next question. Who can do quickly? Why? How come you say that this person is having a ESRD or CRF? What are the indications in the stem that can tell you that this person is having a CRF or ESRD? What is there in the stem?
End-stage renal disease.
Very good. So that's end-stage renal disease, right? So, but that's my question. Like, how can you say that patient is having a CRF or ESRD? How can you say that? What is there in the stem that can tell you this patient is having a compromised kidney function?
The high creatinine and the high potassium level.
Very good. So high creatinine, it's not that high. I'm sorry, 10 times higher than normal. You get 1.2. So creatinine is very high. And the BUN is very high too. You look at the BUN. So there is a high BUN, creatinine, and potassium. All of these three things are high. As we discussed yesterday, creatinine and BUN are the biomarkers that we use in clinical practice to assess the kidney function test. To assess the renal function, we look at level of creatinine in the blood and BUN in blood. They are biomarkers. We use that as biomarkers or standards to assess the degree of damage of kidney. In this case, the level of creatinine is 10 times more than normal, more than maximum limit, and the BUN is very high too. And with increased level of potassium, that all indicate it's a case of CRF or end-stage renal disease. Good job. Good job. One of the reasons why I want to discuss it this way, so you know how to read the stem and how to analyze the stem, rather than just coming down to the answer like, okay, why it's ESRD, what did I put in the stem? It indicates it's ESRD or chronic renal failure. Why we came down to the diagnosis, okay? This will immensely help you when you get to the second year on the board exam, because this is what you have to know, how to dissect the stem, how to read and dissect the stem. Good. Very good job. So let's talk one thing more quickly. Why C is not the right answer? What would happen with the C? Why don't want to give hypertonic saline? Why don't want to inject hypertonic saline? Yes. Why not? Very good. It would draw water out of the cell. Outstanding. And what is the effect of that? And urea, yes. But what is the effect of? Very good. Good job. So you will increase the osmolality of the blood or ECF compartment, and by osmosis it will draw water from ICF to ECF as a first step mechanism, and that will leave the potassium behind in the ICF, getting it more concentrated. It will increase the driving force for potassium to leave the cell from ICF to ECF. It will result in hyperkalemia. It will make the hyperkalemia more worse because of the movement of the water from ICF to ECF. And when you move water out from ICF, you will make the potassium staying behind in the ICF, making it more concentrated, which will increase the electrochemical gradient for potassium to leave the cell, which will increase the driving force, and that will result in more hyperkalemia, and that will make this condition more worse. That's why hypertonic saline is not the right answer. Okay. You talk about beta blocker, beta agonist already, so you know beta blocker already, and you know about alpha agonist. We talked about that yesterday as well. So A, B, and C and D are very clear to you now. We'll talk about spironolactone or aldosterone antagonist in the next question. Okay, we have a question coming up. Beta blocker, as you know, because it will inhibit the sodium potassium ATPase activity and will also result in hyperkalemia, right? We talk about that. So because you're blocking it, beta receptor, so it will inhibit the sodium potassium and then will inhibit the shift of potassium from ECF to ICF, and that will result in hyperkalemia. So beta blocker will make it more worse. Okay. Alpha agonist has the same effect. When you give alpha agonist, what would happen with alpha agonist? Why it will make it more worse? Alpha agonist. We talked about it yesterday. Alpha agonist.
It will shift the potassium out of the cell from ICF to ECF, making it worse.
How? How? So what is the effect of alpha agonist on the sodium potassium ATPase pump? Is indirect effect, but what it will do? Will that inhibit or activate?
It will inhibit it.
Very good. Outstanding. Or remember that, okay? That's a mechanism. So remember that. So we talked about all of this yesterday. Just remember that. And we'll discuss about this more questions. All right, I'll start the poll now. It's very interesting questions. It's all clinically relevant, applicable, and enhance your understanding of the concept. I wrote all of this stuff to make you learn the information about each and every diuretic here. So make sure you read everything what I put in the distractors and in the stem.
I just want to clarify something. So alpha inhibits the sodium potassium ATPase pump, and
Yes.
the beta activates that.
Yes.
Okay.
Good. Correct. Very true. Very true. Very true. I'll give you more time because it's too much to read, but very important for you to read and understand. So this way you can educate yourself that why we are learning these all the diuretics or renal physiology and pathophysiology, because you have to use this in your practice one day, especially with diuretics. So that's why I put all this information to make you understand that you are not learning anything in the vacuum. Everything what you learn has to have applications in the clinical world. Renal will be tested heavily on the board exam also. It's a big system, it's a dense, little complex, same like cardio somewhat. It's heavily tested in exam in on board exam. So and for our exam also, it's a big chunk. More than 50% of the renal mod is physio on Wednesday. Give it 10 more seconds. 5, 4, 3, 2, 1. Gonna end the poll. No worries, it's not being graded. I'm just running the poll just to all of us understand where do we stand in terms of knowledge or understanding this subject so far. So you can prepare accordingly and fill the gap. Okay, you can bridge the gap, fill the gap wherever you find out any gaps in your understanding or knowledge. Okay, so who can explain that? It's a very good, interesting question, and you have to be careful when you prescribe this drug. Especially, when the patient is taking ACE inhibitor or beta blocker, cardosteroid beta blocker, or angiotensin receptor blocker. I didn't put it here, but any of these drug, then you have to be careful if you prescribe each of the following drug, which you should avoid it. So the answer is aldosterone antagonist or blocker or inhibitor. The example is spironolactone. Anybody can tell me why A is the right answer? Yes, Mrs. Abraham.
So for my approach for this question, so I read that the patient's on an ACE inhibitor, so we know they're having a block from the lungs from the ACE enzyme converting angiotensin 1 to 2, and then she's also on a beta 1 blocker, so we know that the renin's not going to be released in the kidney because beta 1 helps release renin, so she's on a double blocker. And then you don't want to give aldosterone because even though it's the last step in the RAS pathway, she's going to be depleted of sodium and then she's going to be depleted of water. So you're going to inhibit almost every step of that pathway. So you don't want to do that at all.
Good. So I agree on that because definitely it will compromise the sodium reabsorption. But what is my concern here? My concern is sodium, whether it is hyponatremia is my concern or hyperkalemia is my concern. What is more clinically important?
Hyperkalemia is more important, but
Very
if
good.
you the
It will
sodium,
result in
it'll
cardiac
raise the-
arrhythmias, right?
Yeah,
It will
it's
result in
gonna raise her potassium and kill her.
exactly. Good. We talked about that yesterday, but good. I love that. Good. Thank you. So hyponatremia will not make any difference in cardiac rhythm. It doesn't have any effect on the cardiac rhythm, or but mainly hyperkalemia they can result in change in the cardiac rhythm or they can result in cardiac arrhythmias, and that is more dangerous or fatal, right? I would worry more about hyperkalemia than worrying about hyponatremia. But you are correct; it will result in hyponatremia. I agree on that, but that definitely is not a concern here. The concern is hyperkalemia. So why hyperkalemia? Why hyperkalemia will occur? Why don't want to give a drug, aldosterone blocker or antagonist who have been taking AC inhibitors or beta-1 blocker? Why don't want to give aldosterone antagonist, or it's called potassium sparing diuretic? The name itself indicates potassium sparing diuretic. That will spare the potassium. It will increase potassium in the blood. So why don't want to use a diuretic which is potassium sparing or aldosterone inhibitor or antagonist in a patient who have been taking ACE inhibitor and beta-1 blocker for last 5 years? Explain. It's cardio. We talk about that. It's not something new that you guys didn't know about that. And I think Mrs. Abraham was on the path there. So that's a hint here. Yes, Amir.
Is it because aldosterone is responsible for potassium excretion? So if you have two inhibitors, that would just lead to a buildup in the blood. If you have an AC inhibitor as well as having an aldosterone antagonist, they both act on the RAS pathway. So that would lead to an accumulation of potassium in the blood.
I love it. Good. What is the mechanism? Good. You are correct. You explained that very good. Why it will increase potassium? What's the basis? What's the physiological basis of increasing potassium with ACE inhibitors and beta-1 blocker? Why it will result in hyperkalemia? What is the effect of ACE inhibitor and beta-1 blocker on the final component of the RAS pathway, which is aldosterone?
Sorry, you said the beta blocker?
Yeah, beta-1 blocker and ACE inhibitor both. What they will do to the RAS pathway?
Wouldn't it oh, sorry, I was thinking about the sodium potassium pump. But no.
No, but you can think about that too. That's another reason we talk about that. Hold that thought. It's a good point, and I'm going to talk about that since we already talked about that earlier in the previous slide. But what is the other reason why ACE inhibitor and beta-1 blocker will do what to the RAS pathway? Simple question. Will that activate or downregulate, or upregulate or downregulate?
Should have downregulated.
Exactly. So when you say downregulate, what would be inhibited? In what components will be inhibited in that pathway?
Renin and any earlier upstream precursor, renin, angiotensin 1, angiotensin 2.
But what about the downstream precursors, downstream components, products?
After that is aldosterone.
Yeah. So they inhibit aldosterone.
Yeah.
ACE inhibitor, beta-1 blocker, they both inhibit aldosterone, right? Good.
Yeah.
So let's finish the circle. Don't hesitate. You are good. You are on right path. So never ever feel hesitant because you guys are amazing. You guys are thinking in the right direction. So make sure you complete the circle. Okay, don't stop in between. Good. So you downregulate RAS system by giving ACE inhibitor and beta-1 blocker, and the last component or last product of that RAS pathway is aldosterone, right? So you basically inhibit aldosterone with these two drugs, and then you give another aldosterone antagonist inhibitor that will make it more worse. Right? So what is that worse? Hyperkalemia, right? Hyperkalemia. When you inhibit aldosterone, it will result in hyperkalemia with these two drugs, because they all have, at the end of the day, they all have the same action on potassium, right? Right. So how all of these drugs, ACE inhibitors, beta blocker, and aldosterone antagonists, will result in hyperkalemia? What's the mechanism? How that will result in hyperkalemia? What's the basis? What's the mechanism? Yes, Erin.
They'll essentially block the channel. Well, for the aldosterone antagonists, like the K potassium sparing diuretics, sodium won't enter, so that means calcium won't leave, and it will just accumulate in the cell, and that's what causes the hyperkalemia. So essentially blocking our sodium potassium ATPs.
Outstanding. I just one small correction. It's not calcium, it's potassium. Okay, I know you know that. You just said, you just misspoke it. It's a potassium, right? So since you inhibit aldosterone, you inhibit sodium channel activity here on the renal epithelial cells, luminal membrane. As Erin said correctly, you also inhibit the potassium channel activity or decrease the expression on recruitment and population or quantity of the potassium channel here in the luminal membrane of principal cells. So potassium cannot you decrease the rate of potassium secretion by inhibiting aldosterone. So since you do not secrete potassium, so potassium will stay here. When the potassium will stay here, it will inhibit this pump, because you have too much potassium, and that will inhibit this pump to push potassium inside the cell from outside. So eventually potassium will keep accumulating inside the cell, inside the blood. That will result in hyperkalemia. Everybody follows it? Step by step. What Erin said is that you inhibit this channel when you inhibit aldosterone. Okay, so when you inhibit aldosterone, you inhibit this channel. So that's why potassium is not going to secrete. So it will decrease the rate of potassium secretion and decrease the rate of potassium excretion. So potassium will accumulate inside the cell. Okay, and when potassium accumulates inside the cell, it will reflexly inhibit the activity of this pump, because there is so much potassium here. So that this pump will be inhibited, because this pump is actually putting potassium from blood to the cell. But there is so much potassium. So there is no gradient for potassium to come in, because there is so much potassium here. And that will inhibit the sodium potassium ATPase pump activity indirectly. And that's why potassium will keep accumulating inside the blood, hyperkalemia. Very good job, Erin. Outstanding. Hyperkalemia. Is everybody clear? Thumbs up or thumbs down? I don't think I said anything new that we didn't discuss yesterday. We discussed everything yesterday. And Erin said the same thing, what I just said that. Yes, Amir.
Thank you, Dr. Shah. I'm sorry, could you just explain that one more time, just so I really understand?
Aldosterone normally will increase the rate of potassium secretion. Agree? What's the job of aldosterone on this sodium?
It's meant to promote potassium excretion.
Good. So now you inhibit aldosterone, right? Antagonist, right? Antagonist.
Yeah.
This is also antagonist. So what would happen to the rate of potassium secretion?
It should build up in the
No, answer my question. Let's go step by step. What would happen to the rate of potassium secretion when you inhibit this?
Decrease. It would decrease.
Right. So what is the sequence of consequences of that? When you do not secrete potassium, what would happen to the level of potassium inside the cell?
It's gonna build up.
Very good. Inside. If this build up, what is the effect of this on sodium potassium ATPase pump?
Well, the gradients are going to be diminished.
Good.
Potassium.
Outstanding. So what would happen?
Well, that pump would be inhibited because they're reliant on each other.
Good. So if that pump is inhibited, what would happen to the potassium?
Potassium, potassium inside the cell is going to build up, but it's going to have trouble leaving.
No, I get that. When the potassium is increased here, you said this pump is inhibited, right?
Yes.
So what is the effect of this inhibition of this pump on potassium shift from ECF to ICF?
It's going to decrease from ECF
Very good.
to ICF. It's going to
so
build up
what would happen
ECF.
because of that? What would happen of the potassium level in the blood because of that?
It's going to, if there's less in, it's going to be less in the blood and more in the cell. No. Sorry, it's going to be more in the blood.
Right. So what is that condition known as?
Hyperkalemia.
There you go.
Yeah.
Got it?
Yeah.
Good. Good.
Thank you.
Good job. No problem. No, it's my job. No worries. And it's very important for the exam too. So I want to discuss it thoroughly. Good job.
Yeah.
Very good. I love it. All right. Start the poll. We talked about this yesterday, so it should be very quick. But I'll give you probably 1 minute here. Still a lot of sentences to read. It's a good revision of what we discussed yesterday. I see students from other campus too. That's good. That's very good. I'll make sure to post the recording for other campus as well, so they all can get benefited from our discussion. I'll stop the poll in 5 seconds. Okay. 5, 4, 3, 2, 1. I'm going to end the poll. Good job. Good job. Who can explain this? Who can explain this? Who can explain this? Yes, Michael.
So looking at the graph, it's sort of like a domino effect where if you have if you have a low potassium diet, you're going to have less potassium in the blood overall. So that's going to increase the concentration gradient between the cell and the blood, wherein more potassium flows out of the cell and into the blood through channels. And that's going to increase the concentration gradient between the lumen of the tubule and the cell, so that the ATP pump can take in more potassium from the lumen to the cell.
Okay. Will that take? You are correct. Very good job, Michael. Will that take or will that inhibit? Sodium potassium ATPase pump is inhibited or will get activated? You are correct, but you said something that a small correction. You are correct. If you are on a low potassium diet, you have a low potassium in the blood, right? In blood, Michael. That means it will decrease potassium filtration from filtration barrier. So that means less potassium is there in the tubular fluid. Am I right? That's what you say, right? So that means there is a big gradient for. Now there is here this is decrease in tubular fluid. What would happen to the blood in the blood? At first place, you have a decreased potassium in the blood, right? Because you eat less potassium diet. So what would happen in blood for the potassium gradient?
Well, if you have the low potassium diet, there would be less potassium in the blood.
Right.
So that means there would be more potassium in the cell, and that would make a higher concentration gradient, right?
Right. That is true. But what would happen to this pump?
Oh, that pump's going to be inhibited.
Yes, good. So because at first place you have a low potassium in the blood, so because the potassium is low, that pump is inhibited in order to push less potassium from blood to cell, right? Right. So that will actually try to compensate hyperkalemia. Agree? Right? That's one of the mechanism. Now, second mechanism is this: since you also filter less potassium in the kidney, right? By kidney, right? So that means less potassium is here. So this pump will be activated to reabsorb maximum potassium from lumen to the cell. Agree? Right? And whatever is coming here will be diffused down its gradient from cell to the cell to the blood, because anyway blood has a low potassium, right? There is a large gradient for potassium to exit or reabsorb from cell to the blood, right? You follow? So that will correct hypokalemia. All right. Good job. Outstanding. I love it. Remember that this called alpha intercalated cell, and that's the only cell here in the distal tubule collecting duct, late distal tubule collecting duct, which has the process of potassium reabsorption by a primary active transport mechanism, which is called hydrogen potassium primary counter transport, primary active counter transport. Okay, so same transporter you have in gastric parietal cell, right? You learn in GI, same transporter you have in gastric parietal cell, hydrogen potassium ATPase pump is a counter transport. You learned that in GI, same transporter we have, and this transport is primary active transport because look, it has ATP, it has its own ATP, which will be consumed and that will really absorb. For maximum, it will try to reabsorb potassium from the luminal fluid to the cell and from cell to the blood, because there is a low potassium here, which will create a big gradient for potassium to diffuse easily from cell to blood, right? That is a compensatory response of to correct hypokalemia from low diet. Right, Michael? Good job. I love it. Yes, Mrs. Abraham.
I have a good question. So if the question was not a primary active transport, where would it be in the nephron then? Will it be in the proximal tubule or?
Yeah, if that potassium can be reabsorbed from any other segments, we talk about that, right? It could be absorbed. You're correct, from proximal tubule. You also from other thick loop of Henle, we talk about. So yes, you reabsorb potassium from other places too, right? But they all are secondary active transport, right?
Okay, yeah. So for the secondary active, where would that be? I think that's
I'll hold that thought. Hold that thought. We're gonna go to that question. If you recall correct quickly, we discussed it today and yesterday. It is located on the luminal membrane of thick loop of Henle, right? NKCC co-transporter, right? So that will probably reabsorb 25% of potassium from thick loop of Henle into the blood, right?
Okay.
That's that, but that's a secondary acute transport, right? Not primary.
Secondary for loop.
Yeah.
Okay.
Because they use ATP from a sodium potassium ATPase pump. They use a sodium gradient, which is created by a sodium potassium ATPase pump, which are located on the basal membrane of thick loop of Henle, right? Right. So they are all secondary active co-transport, right? You follow?
Okay. Yes, sir.
Yeah. Okay. Good. Now, one more difficult question. I really don't want to discuss, but I think you guys are doing an amazing job, and I want to talk about that. If the potassium is low here, that means there is a low potassium in the fluid here, right? We all discuss about that, which is also going in the same to the principal cells. So principal cells are exposed to the low potassium in the tubular fluid here. How principal cell will react to that low potassium in the tubular fluid? Tell me. What will happen to aldosterone? That will also help in correcting hypokalemia. It's not in the stem, but I'm asking you, what is the other mechanism that will help you to correct hypokalemia in this patient? What will happen to level of aldosterone? I can give you the hint.
Can't you decrease aldosterone? So
Good. Super.
potassium.
Outstanding. 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 Good. Now you got it. Good. All right. We talked about this yesterday. So let's review this one more time. And then I'll start the poll, and then we can go to other questions on diabetes problem. You can start open the other PowerPoint presentation after this question. Read this carefully, okay? I know master students already taught it today, so they can probably answer half of this question. I mean, they can answer. There are two answers in each line. You can know one thing at least. The DO students. For MS, they should answer both. We talk about that in the class today. Thiazide diuretic. I'll stop at 5 o'clock. Okay, I know you have a class. Somebody told me you have a biochemistry supplemental, so I'll stop at 5 so you can go in that supplemental as well. Everything is important. Ten more seconds. 5, 4, 3, 2, 1. Stop the poll. Good job. All right. Who can explain this? Anyone? We talked about it yesterday, so at least you can explain hypokalemia part, and even master students, because we discussed it today, so they can even tell me why hypercalcemia is also correct. Yes, Erin.
I can definitely explain the first part.
Yes.
So for thiazide diuretics, we're inhibiting NaCl reabsorption. So if we have less reabsorption, we're going to have more sodium delivered to the collecting duct, and that will mean the principal cells will reabsorb more sodium and then therefore essentially secrete more potassium, resulting in hypokalemia.
I love it. Outstanding. Outstanding,
I
Erin.
think the other one has something to do with the sodium calcium exchanger, but I'm not sure.
You're correct. You're correct. We'll talk about that tomorrow, but you're correct. I discussed it about today, so it will basically inhibiting sodium chloride co-transport. It will indirectly, change the gradient for sodium. So since you inhibit the sodium chloride co-transport inside the cell, basically there is less sodium inside that will create a gradient for sodium calcium exchange to be operated more quickly or more vigorously. So when there is you inhibit this transport by thiazide, you don't reabsorb sodium, and when you do not reabsorb sodium, there is another pump which is working here. It's called sodium calcium exchange, which is electrogenic in nature. Once 3 sodium can exchange with the 1 calcium, so that's why it's electrogenic. The stoichiometry of that pump is 3 sodium and 1 calcium. So there's 1 plus extra that makes the pump electrogenic in nature. And when you decrease sodium, that's then there is a gradient for sodium is developed here inside the cell, and there is a sodium calcium exchange which is operated here. So when there is a gradient here, sodium can easily come inside. When sodium comes inside, calcium can easily go into the blood. Okay, we'll talk about that tomorrow. I have that slide, and I discussed it with the MS class today with the animations. Actually, I created animation step-by-step process how it will indirectly increase more calcium reabsorption by inhibiting the sodium chloride co-transport on the luminal membrane of early distal tubular epithelial cell, and how that will decrease the sodium here, which will basically create a gradient for sodium to come in. So more sodium will come in, and that will occur at the cost of increased calcium reabsorption from cell to blood. Hypercalcemia will develop. All right. But for now, let's focus on hypokalemia more, at least because we talk about that, and Erin explained that really well. When you absorb less sodium in the early distal tubule, here if you have absorbed less sodium here by because thiazide will inhibit this transporter, this sodium will be delivered to the late distal tubule collecting duct, mainly principal cell, and under the effect of aldosterone, under the direction of the aldosterone. Remember, it's a fine tuning segment for sodium and potassium regulation. So aldosterone will reabsorb sodium, which is delivered from thick loop of Henle because it's not absorbed here, and all the sodium will come down here, and then it will be reabsorbed completely with the effect of aldosterone, and that will occur at the cost of increased potassium secretion, and that will result in hypokalemia. Now I will add one more thing. Why it will result in mild hypokalemia? Why it's not profound hypokalemia, but why it is mild? Why it is mild hypokalemia? Because you only inhibit 5. Yes, Erin.
Is it because some of it leaks back out?
Yes, but mainly you only, if you look at the distal tubule or early distal tubule segment, they only reabsorb 5% of sodium, right, Erin? So the job of reabsorption of sodium at early distal tubule is small quantity, right, Erin? So it's not affecting much sodium reabsorption because only 5% of sodium is reabsorbed, right, Erin?
Got it.
That's why. So less sodium is so very small amount of sodium reabsorbed. So and you inhibit that. So very small amount of sodium will be floating in the tubular fluid, which will be delivered to the principal cells. So less sodium is going to the principal cells. Less potassium will be secreted and excreted. So that will that's why there is a mild hypokalemia, right? Mild. Good. Outstanding job. Let me open the other one. Let me share the other quick other one. This thing. It's very important. I will talk about diabetes. Very important for the exams. I want to talk about that quickly. And then I'll let you guys go. Okay. That will take probably 15 minutes maximum. Okay. You can see the slide, right? New presentation. You can see that?
Yes.
Good. All right.
Yeah.
So let's talk about this question. I'll start the poll. Very important question for the exam for practice is diabetes. Common clinical presentation in practice. Just 10 more minutes and we are done. Maybe 15 minutes. You guys are doing good job. Okay. You guys are amazing. Very good job. Keep revisiting the information again and again. So that will solidify your understanding. Okay. But you are doing good job. Yes, you're correct, Mrs. Abraham. You have to pick up the answer very carefully because it's a little tricky, the distractors. I'll give you 10 more seconds. 5, 4, 3, 2, 1. We'll stop the poll. All right. We ended the poll. Good result. Good job. Who can explain that? Who can explain this concept? Why it's SCl2? What's going on here? Anyone? Anyone wants to try? Yes, Mrs. Abraham.
I can try. So, based on what I recall from the textbook, In the proximal tubule, of course, sodium has a lot of imports and glucose is one of them. However, you can technically saturate it too much, then it starts to inhibit it crossing the membrane. So its transport maximum is reached. So at that point, you slowly will start to lose glucose. And this is popular in people with diabetes. They have too much sugar, so they can't reabsorb the glucose, so they'll end up peeing it out. You've fulfilled all your transporters theoretically, like there's no more to go in.
Very good. Outstanding. Super. Very good job. So why it is SGLT2 but not SGLT1? That's my first question. And why I said that they are operating at its maximum capacity. Why it's called I put it maximum capacity. So what's going on here? What's the technical wording or explanation that we use here what is happening here? And we talked about this yesterday when we discussed about the luminal potential for different segments of nephron. You know that there is a secondary active core transport existed on the luminal membrane of the proximal tubular renal epithelial cell. So this is early proximal tubule, and this is the late proximal tubule. And the luminal membrane, we have a SCLT2 here in the early proximal tubule. That's mainly populated here. In the late proximal tubule, you have a SCLT1 populated here, mainly, or expressed here, you can say. But why they will get saturated? What's going on here when the filtration of the glucose is so high, filtered load of glucose is high from the previous question we discussed yesterday, the calculation. What would happen in kidney? That will result in spilling of the glucose in urine. It's called glycosuria or glucosuria. Why? What's going on here? What would happen? I mean, Mrs. Abraham explained that all correctly, but if anybody wants to elaborate it further. So what would happen when this particular transporter is exposed to very high level of glucose load in the tubular fluid? What is the job of SCLT2 transporter here? What is called sodium glucose co-transport, right? We talked about that yesterday also, which are located on the luminal membrane of proximal tubular epithelial cell. So that will bring sodium and glucose both inside, right? Sodium comes. What is the gradient here? What gradient is being used here? Tell me. Why sodium will come inside and glucose will also come inside? What is downhill and what is uphill transport here? Sodium will come inside, right? I told you secondary active transport. So why it's secondary active transport? The sodium potassium ATPase pump, right?
Yes.
Will create a gradient for sodium, and that using that gradient, this SGLT2 will operate, right? That's what we call secondary, because it is depending on this primary active transport mechanism. It is depending on this, because this will create the gradient for sodium here. We talked about that yesterday, right? As a reminder. So that gradient will operate this SGLT2 transporter that will bring sodium and glucose both inside. So sodium will come downhill, right? Right? Because there is low sodium here and glucose will come uphill, right? And they will exchange the energy to move that. So glucose will come uphill against its electrochemical gradient, and sodium will come down its gradient. This is how you can get glucose inside. And once the glucose is inside, that glucose will be diffused using this GLUT2, carrier-mediated transport is called facilitated diffusion. Facilitated or aided or facilitated diffusion for glucose from cell to blood by GLUT2 transporter, which are located on the basolateral membrane of proximal tubular epithelial cells. Okay, so glucose comes inside uphill, and there is a high glucose concentration. Now there is a high glucose concentration here. Then glucose will start diffusing, moving from here to here, using this carrier-mediated transport clause or GLUT2 is called facilitated diffusion. Facilitated diffusion of glucose from cell to blood. Okay, this is how it will happen. So in case of high level of glucose load in the urine, these transporters have a very finite capacity to bind to the glucose molecules, right? So what happens is that if it is exposed to very high level of glucose, then it will start saturating. All the binding sites on which glucose bind on these SGLT2 transporters, they will start saturating. Okay, and because such a high level of glucose here, so almost all sites will be saturated when you reach to the level of 200 milligram per deciliter of blood. Okay, that's called renal threshold. So when you reach to renal threshold, after that, all the transporters will start saturating quickly. And that's why some of the glucose will be reabsorbed up to 200. Some of the glucose will remain in the tubular fluid. It will be spilled in the urine. It's called glycosuria or glucosuria. Okay, so up to 200, the glucose can be absorbed. Glucose can still be absorbed, but after 200 glucose in the blood, the transporter will start saturating, and there's a decline reabsorption of the glucose from lumen to the cell, because it will exceed, when the level of glucose is so high, it will exceed the capacity of the transporter to reabsorb glucose from lumen to the cell, because all the binding sites on transporters are saturated or will start saturating. Okay, so less binding sites are available between 200 and 400, which is called splay. And when you reach to 400, after 400 milligram of glucose in blood, all the binding sites will be saturated by this time. No glucose will be reabsorbed after that. Okay, and all the glucose which is filtered will be just excreted directly after 400. Okay, all right. So up to 200, most of the glucose will be reabsorbed. Most of the glucose is called renal threshold. And renal, that's the capacity of kidney. It's called threshold. Is how much I can do. That's what how can I do, renal threshold. So renal can reabsorb glucose up to 180 to 200 milligram per deciliter of glucose in blood. Okay, after that, the transporters or carriers or binding sites which are there, the transporters will start saturating and they will bind less glucose. Okay, so some glucose will bind and will be reabsorbed. Some glucose will just stay in the tubular fluid and will be spilled out in the urine. It's called glycosuria or glucosuria. Okay, but once you reach to 400, after that, all the glucose will be spilled in the urine, will remain in the urine. None of them will be reabsorbed because all the binding sites on these transporters are saturated, and that will result in profound glycosuria or glucosuria. Okay, now I'll explain that in the next slide one more time. Now, why SGLT2 is the right answer here than SGLT1? What makes you to pick up SGLT2 here than SGLT1? Why SGLT2 is better than SGLT1? SGLT2 is a low affinity, high capacity transporter. Okay, SGLT1 is a high affinity, low capacity transporters. Why it is like that? Why these transporters are very highly capable, but low affinity? What's the logic behind that? Simple logic. What's the logic? Why these transporters, nature of these transporters is high capacity but low affinity. Nature of this SGLT1 transporter is low capacity but high affinity. So why it is like that? Yes.
Is it because at the beginning of the filtration there is a massive amount of glucose which will be more easily bind?
Yes, outstanding. Because these early proximal tubular epithelial cells are exposed to very high level of glucose before the glucose goes to late proximal tubule. It's very logical. So this particular lumen is very has a very high glucose, and this particular transporter is exposed to a very high level of glucose load in the tubular fluid, and that makes the nature of SGLT2 transporter high capacity but low affinity. It doesn't require that much of affinity. There's so much glucose is there, but it requires so much of the capacity because so much glucose to move from lumen to cell and to the blood eventually. So that's why these are high capacity, low affinity transporters, as opposed to this one, which is low capacity, high affinity transporter. Because by this time, when you come here, the glucose is very small amount left in the tubular fluid, and that's why this transporter has a very high affinity, so they can get all that glucose, whatever is left over, which is not reabsorbed here, and then they can carry from here to cell and then eventually the blood. But it's very small amount of glucose, so this transporter doesn't require that much of the capacity. Okay, it's a weak transporter, and this is a very strong transporter. And logic is very simple, as you said earlier correctly. Very good. Now, good. Let's go here. Now let's talk about glucose titration curve, where the glucose kinetics of glucose or glucokinetics is plotted as a function of the plasma glucose concentration on this graph. Okay, so this graph, the glucokinetics process, glucose filtration, reabsorption, and excretion is plotted as a function of the plasma glucose concentration on this graph. It's called glucose titration curve. Glucose titration curve or graph. So this will explain what I just told you earlier in a more simple simple way, because that's a graph plot, and you can easily see the relationship across different variables here, how glucose process of filtration or excretion or reabsorption will be changed, how the whole glucose dynamics will be changed, or tubular transport dynamics of glucose will be changed at different level of glucose concentration in the blood here. It's called glucose titration curve. So let's start with very basic stuff. This is called, we talk about renal threshold. So this is called renal threshold, right? Around 200 milligram per deciliter of blood. So suppose we reach at 200 milligram of glucose in the blood. And that is all filtered, right? So what would happen to that glucose? It's filtered, right? Same amount will be filtered. Now, how much of them will be reabsorbed? Tell me. It's very simple. This curve is actually very simple. How much of them will be reabsorbed? I told you that earlier. Look at the line. The yellow line, dashed line, broken lines is a curve of reabsorption, and this purple or whatever the color is filtration line, or this green line, broken line is called line for excretion. So tell me, when you reach a 200 milligram in blood, you are filtering all, and what would happen to the reabsorption at that time, up to 200 milligram?
You'll have 100% reabsorption.
Very good. That's why the curve of line of reabsorption is overlapping with the line of filtration, right? Whatever you filtered will be reabsorbed. So no excretion. Agree? No excretion. That's why if you look at the curve of excretion, line of excretion, it's straight line, right? No change in excretion, because whatever is filtered up to 200 milligram, this is called renal threshold. They all will be reabsorbed by SGLT2 and SGLT1 from proximal tubule. Agree, everybody? So whatever is filtered will be reabsorbed. That's why the line of reabsorption is overlapping to the line of filtration up to 200. Agree? Okay. After 200, you see this, it will bend. It will bend, and then it will level off. So if this is called hashed, either it's called hashed area, it's hashed. So this hashed area here, the blue hashed area here, you can see there's a band, the glucose, this reabsorption line will bend here. And so whatever is filtered after 200, up to 400, what would happen to that glucose? Tell me. Between 200 to 400, what would happen to that glucose? Tell me. Look at the lines. Look at the curve, the titration curve.
So after 200, you still have reabsorption, but it's slower.
Very good.
So
it will decrease reabsorption from between 200 to 400, right? That's called splay. That's called splay. So between 200 and 400 milligram, you will reabsorb some glucose, but you will also spill some glucose in urine. Why? Because the transporter will start saturating, right? They are not completely saturated yet, so binding sites are still available for glucose to bind, but some of them are available, some of them are saturated. So some glucose will be will bound to the transporter, some of them will be spilled in the urine, right? That's why this curve will bend. So whatever is filtered after 200, between 200 to 400, some of them will reabsorb and some of them will be excreted. Look at this. It's a mirror image, excreted, right? Some of them will be excreted between 200 to 400 and some of them will be reabsorbed. Everybody follow that? Thumbs up or thumbs down? It's a little difficult, but you have to look very carefully. It's not complicated. After between 200, this is 200, this is 400. Between 200 and 400, whatever is filtered, this is filtration, line of filtration. Whatever is filtered, some of them will be reabsorbed, right? You can see that. Some of them will be reabsorbed, and some of them will be excreted here. You can see that. It's mirror image to reabsorption line. So that means some of them will be reabsorbed by the transporters because they are still available. Some of them are still available. Some of them are saturated. So they will not reabsorb, but some of them are available which will reabsorb it. And that's why the line of reabsorption will curve like this up to 400, right? Less absorption and some secretion and excretion, right? Right. So if you lose glucose in the urine, it's called glycosuria or glucosuria. After 400, it's very simple now. When you reach to 400 milligram of glucose in the blood, what would happen? Whatever is filtered after that, look at that. What would happen to the reabsorption? Tell me. Look at the line here. At 400, this is the curve of filtration. This is the curve for reabsorption. What would have to happen after 400?
It reached saturation, so there's no more reabsorption. That's
Love it. Good. That's why the curve, the line of reabsorption will level off. Agree? Because whatever is filtered, you cannot reabsorb nothing out of that because all the transporters are saturated from 400 milligram and onwards, right? right? And this number 400 is known as transport maximum. That's a maximum a transporter can transport. It's called transport maximum or TM. That's a TM or transport maximum. That's a maximum because can be transported at 400 level, because at that point all the transporters are saturated. All the binding sites on transporters are saturated. So all the glucose which are filtered will be completely excreted here. So look at this, whatever is filtered, this line of excretion is parallel to line of filtration. Very simple to see it. All the glucose which is filtered after 400 here, from 400 here to here, this all will be excreted directly. This is line of filtration is parallel to line of excretion here, because no glucose will be reabsorbed after 400. So this line filtration and the line of excretion is parallel to each other. All right. Good job. Okay. If anybody has any
Dr.
questions,
Shah,
they can ask
yeah,
me
Dr.
now.
Shah,
Otherwise, you can leave. Yes.
I just wanted to clarify. So when the filtered line and the excreted line are parallel to one another, that means that anything that's filtered at that point is automatically excluded. Is that correct?
Exactly. Good.
Okay. Thank
Because
you.
you don't reabsorb, because all the transporters are saturated, right?
Okay,
You
perfect.
cannot